This is CVPR622, Perfusion Techniques 2. And today we are going to discuss the topic, CO2 flushing the surgical field. This is an important technique, and it has its roots in one of the bigger problems with cardiopulmonary bypass. And it's where we get the term don't pump air. And if you look back, way back in the Annals of Surgery, 1953, there was a paper written, The Mechanism of Death from the Intracardiac Air and Its Reversibility. And in this, in their introduction, they said there's three possible mechanisms of death from air in the left heart have been considered. One, air entering and occluding the coronary arteries. So if air gets into the coronary arteries, it effectively blocks blood flow to the myocardium, and it can cause arrhythmias and ultimately fibrillation, and that would cause death. The second, the bolus of air in the ventricle itself, resulting in the failure of cardiac pumping action. So just the air, just depriming the ventricle, and now it's no longer an effective pump of blood. And three, cerebral air embolism. So since the beginning, air entering the heart chambers becomes a threat, and it can kill a person in three different ways: coronary artery air, air in the ventricle, and cerebral air embolism. And so ways to combat that have been considered. And here again, another old paper, 1959, comparison of air, oxygen, and carbon dioxide embolization. This was an animal study, and they were testing. They were comparing what about different gases? Are they different? And they compared air, regular atmospheric air, 21% oxygen, mostly nitrogen, 100% oxygen, and then 100% carbon dioxide. And what they found was that this study gives support to the simple clinical procedure of bathing the field of operation in an atmosphere of carbon dioxide gas. Since it's 1.53 times as dense as air, it should largely displace the air in the operative field, down in that chest cavity. If during open cardiotomy gas is retained in one or both of the heart chambers, the greater concentration of carbon dioxide in the gas bubbles should permit their more rapid absorption into the bloodstream and should lower the incidences of serious complications. So this statement, back in 1959, talks about why CO2 flushing may be important during the operation. The same reason we use CO2 to flush our circuits, because it is more soluble and is easily absorbed, much more easily absorbed than atmospheric air. Then later in 1968, carbon dioxide in the prevention of air embolism during open heart surgery. And again, this is this paper, 1968, so we're moving into a newer decade, but they compared the solubilities, and again, because CO2 is much more soluble, they really wanted to test to see how effective it was. And so they had a model chest cavity, and here's the chest cavity. CO2 was being filled, and they used a sucker to see at what point was the CO2 being retained in the chest. And when 67% of the CO2 before the sucker was switched on, and 1 minute after the sucker was switched off. So they actually were doing studies to see CO2 is heavier than air. It will sink right into that chest cavity. When they open up the heart chambers, the gas that is in those chambers is CO2. And so when they close the chambers, any retention of air, of gas in that ventricle is going to be CO2, and therefore more likely to be absorbed because it's more soluble. But at the same time, using carbon dioxide in the operative field did have an obvious complication. carbon dioxide acidosis during open heart surgery. So you can imagine that CO2 can cause a respiratory type acidosis if it's in high concentration. So if we remember our handy equation, as CO2 goes up, it pushes the equation to the right, resulting in an increase in protons, hydrogen ions, which would, of course, pH is the negative logarithm of the hydrogen ion concentration, and so the pH would go down. So CO2, an increase of CO2 in the blood is going to push the equation this way. So you may ask, well, how is the CO2 concentration of the blood going to go up if we're simply bathing the operative field in CO2? Well, let's look at that. Here's a CO2 source of some sort, and there is a tube in the operative fields, and CO2 is spilling into this chest cavity, largely displacing any air. So CO2, 100% CO2, is going into the operative field. CO2 in brown here. So what else do we have in the field? Well, we have a sucker, and we have vents. And this is pulling that CO2 right out of the chest, and it's putting it right into our venous reservoir, and it's creating a layer of CO2 right on this blood gas interface. And so right at this interface, we're having CO2 going into the blood. And so we have to be aware whenever we're using this technique of CO2 flushing that our CO2 in our blood is going to go up right at this level. We're having CO2 equilibrating in the blood in the venous reservoir, and that's a fairly large surface area in there. And this was written on in 1998, severe hypercarbia during cardiopulmonary bypass, a complication of CO2 flooding of the surgical field. And it makes sense if you think about it. Clearly, the way you would combat that is to turn up your sweep gas to blow off that extra CO2. So probably if you're using CO2 flooding of the surgical field, it might be really important to have inline blood gas monitoring that actually measures your CO2 at the outlet of the oxygenator. So one of the summary statements that they gave in this article, we describe a case of profound hypercarbia during CPB as a complication of CO2 flooding used to prevent air embolism related to the open heart procedure. We recommend that the technique of CO2 flooding be limited to the part of the de-airing procedures near the end of bypass, rather than being used while the heart is open but not ejecting. And so they really said, don't do it through the whole case. Do it only when we're in the de-airing procedures towards the end of bypass. And this was out of the Journal of Extracorporeal Technology in 2001, Carbon Dioxide Field Flooding, a retrospective study. I apologize that this wasn't animated correctly. I will try to correct that for you. But while the heart was opened and the blood gas was flowing at 10 liters per minute, that's the CO2 flush was at 10 liters per minute continuously. What they found was the limiting factor was the ability of the oxygenator to blow off the CO2. So since some of the early studies, oxygenators were not as efficient as they are today. We were not able to just simply turn up the sweep rate and get rid of that CO2. But today we have very efficient of oxygenators. And so their summary statement was, it was interesting because they described that in the last 6 months, surgical and perfusion techniques have been modified to accommodate the carbon dioxide surgical field flooding technique, and this has been proven to be a very worthwhile technique in their observations. It became apparent through observations after instituting this technique that patients are now waking up more alert than in the past. In addition, the stroke rates diminished greatly among the valve cases. Reviewing the discharge summaries of patients in the last year revealed that only one valve case in the past 9 months has had a stroke, and that patient had carotid disease also. This is opposed to the previous 6 months of the last year, which revealed a total of 6 valve cases each resulting in stroke. In retrospect, it appears that the technique has had a profound effect on our results. Well, this is a retrospective study, and it's sort of a, this is not strong data. It's just observational data that they are presenting. But it does appear that it has an effect at their institution. Looking to a larger study, and this is out of the Annals of Thoracic Surgery in 2008. So now we're getting to more contemporary trials. This was out of Germany, and they actually looked at 80 patients, so a fairly strong N, and they were undergoing heart valve operations. And again, you look at these patients. True open heart surgery, a CABG operation, you're operating on the surface of the heart. When you're doing a valve operation, you're opening up the heart chambers, exposing them to atmosphere. And that is where the CO2 flushing technique has found its greatest popularity in these patients. Anyways, let's look at what they studied. It's really important to look at the methodology. How do you tell? They had two groups. One was the control group with no CO2 flushing. The other was a CO2 field flooding group. And what they did is they looked at some neurocognitive tests consisting of 6 different tests. And then they looked at actually a measurement of brain function called the P300 wave auditory evoked potentials. And so this is actually being able to measure some of the activity of the brain. So some pretty interesting methodology here. And what they found was that they had this test, this P300 wave auditory evoked potential, was indicated less brain damage in patients who underwent heart valve operations with CO2 flooding of the thoracic cavity. Even if these findings were not supported by clinical results or neurocognitive test batteries in our cohort, carbon dioxide field flooding has proven efficacy and should be advocated for all patients undergoing open heart surgery. That was their conclusions. Along this line, and even a more recent study looked at the influence of carbon dioxide field flooding in mitral valve operations, again, true open heart surgery, with cardiopulmonary bypass on the S100 beta levels in blood plasma in the aging brain. So this is an interesting article. I've posted this one. I want you to read it. Understand this serum 100 beta marker. It is a marker of brain damage and blood-brain barrier problems, breakdown. And so it's a bad thing to see rises in S100 levels. They looked at a study here, and they looked at compared groups of older patients with younger patients having mitral valve operations and the effect of field flooding on those. And again, they concluded that there was some very positive aspects of CO2 field flooding. Now in class, I want us to sort of discuss a few things to discuss in class, to think about. So bring your questions and ideas regarding this. Number one, how do we get the CO2 into the field? How do we do that? Just practically, how does that happen? Secondly, the rate of CO2 gas flow into the chest cavity. How much? Do some. Poke around, Google it. What is the usual rate of CO2 flow into the chest cavity? You'll see in some of the papers it's a pretty higher number. Is that the normal? What is the gas flow rate for CO2 flooding technique? And then what about the timing? We had that one paper saying, hey, just do it at the end of bypass. What do other people say? What do you think? Do you think that's important? Do you think we just have to pay attention to CO2? And the other thing is some of the outcomes, some of the potentially better outcomes, do you think that's due to reduction of microemboli? Or could it be that CO2 is causing changes in cerebral blood flow that improve cerebral perfusion? And maybe that is the point of that. And then the other thing is, how would NIRS fit into CO2 flushing? Do you think that would be a valuable adjunctive monitoring device when you flood the field with CO2? And why do you think that? So I look forward to talking to you about this in class. I will post some questions, hopefully before the class. But this is going to get us started. So go to Blackboard, read the papers, and let's get ready to talk about CO2. Thanks, guys.